I'm pretty excited. I've been waiting for this lecture. I kind of know some stuff about entrepreneurship and labor economics, but health is what I'm all about. So to start, I want you to think about what at least I interpret as the conventional wisdom about healthcare in the United States, which is that the U.S. compared to every other developed country, we spend more. We're the only people without universal health care. We're the only people without single coverage. And we're the only rich country with a free market healthcare system. All right. So I labeled this as conventional wisdom. So you might think I'm setting you up to say this is all wrong. Almost. I would say this is half wrong. And so you get to try to think about which half. And as a clue, I've got some data about spending. Right, so the first thing you might notice here is the U.S. is on the far left, spending way, way, way more on healthcare per capita than everybody else. Okay. Over $7,000 per person per year, right, which is about something like twice, a little more than twice what other countries are doing. Okay. So I would say that first part is true. We really do spend a lot more than everybody else. And this thing about not having universal coverage, yeah, that's kind of true as well. Right? So before the ACA in 2009, about 18% of Americans were uninsured, which is a really big number. Right? Compared to other developed countries, most don't really get above 2% of the population being uninsured. But this method that we're using to provide people insurance of private employer-based companies for the most part, that's actually not so weird. You hear about the single-payer systems of, say, Canada or Great Britain, where the government is financing most healthcare directly. But if anything, it's really Canada and Great Britain that are weird here, right? I think people hear about them and assume that, well, everybody in Europe must do it that way, right? It's actually not true. Private insurance is really common, and you can get it in a lot of the countries that we think of as having well-run healthcare systems, like Germany, France, Italy. So first of all, this graph is breaking down private and public expenditures on health, right? So the lighter part at the top of the bars is private expenditure. You're seeing some of that everywhere, an unusually large amount in the U.S., although not a huge percentage. And now in this graph, you can see how much private insurance is spending as a percentage of the market, and how much people are spending out of pocket, right? Spending without insurance. So one thing you can notice here, the US does have a relatively large amount of healthcare being financed privately, right, through private spending, private insurance. Right? But this idea that Americans are having to pay for the healthcare out of pocket, right, making the system about money, that's not the case in other countries, that's simply not true. In fact, Americans pay an unusually low amount out of pocket. Right? So you can see we're paying about 13%. Right? The United Kingdom, right, famous for their socialist, communist, national healthcare system, right, actually paying exactly the same amount out of pocket, 13%. And some of the other countries that are famous, again, for having good healthcare systems, like Italy, regularly ranked number 1 or 2 in the world by the World Health Organization, people are paying even more out of pocket as a proportion of spending than we do here. Right? So what does that tell you? Well, I would say this is some information that, again, we're not so weird in our use of cash and our use of getting people to pay out of pocket and the extent to which consumers are making decisions in our system. So other countries are having consumers pay money. Other countries have, for the most part, private providers as well. Right? We're not unusual in having lots and lots of privately owned hospitals. Again, if anything, Britain is more the outlier here, right, for having their national government run all of the hospitals. So one message I'm trying to get across is when you think about the healthcare systems of different countries, right, I think the usual narrative is the US has a free market system, nobody else does. Right? And so then depending on how you think of the effectiveness of US healthcare compared to other countries, right, that leads you to make a judgment about the effectiveness of free markets. Right? So either people have to say the US is the only place with a free market system and it's terrible, right? Healthcare here is terrible, so free markets must be terrible, right? Or conversely, you might think healthcare here is great, so that must mean free markets are great. But I don't really think that's the way to evaluate things, because I don't think we have a particularly free market in healthcare here, and I'll get to why. And at the same time, I don't think most other developed countries have much less of a free market than we do. All right. So I'm kind of saying that the United States isn't so weird, right? We're not so exceptional. But there is one way in which we really are weird, in which we really are that exceptional, and that's in the total amount of money we spend on healthcare. So this is US spending on healthcare as a percentage of GDP over time. Right? And you can see it going up and up and up, way faster than in other countries. And this is as a percentage of GDP, right? Our GDP is also growing faster than most of these other countries. So showing this in dollar figures, it would be an even more prominent increase. So this is a big puzzle. You know, what's going on here? Is it a good thing, right? Well, a lot of this care is probably wasteful. It's certainly on track to bankrupt the federal government, as you saw in some earlier talks. Right? A lot of this is coming from Medicare. So, you know, almost everybody does think of this big increase in healthcare spending in the US as a problem, especially if this trend continues. So it's a big thing we want to explain. We want to figure out what's going on, what makes the US so different here. And to the extent that we do have a more free market system, is this discrediting that system, right? Is it saying, like, we're just going to end up blowing all of our money? So to think through that problem, and think about whether markets can work in healthcare in the first place. So again, going back to principles of microeconomics, so try to remember back those of you who took it. If not, get a really quick lesson here. So the way a lot of principles of microeconomics classes go, you spend maybe the first half of the semester learning about how these really highly stylized markets work that we'll call basically perfect competition, markets working perfectly well, perfect information, all of that. And then you'll spend the second half of the semester tearing all that down and saying, well, but in practice, there are all these market failures, and these are some of them. Okay? And one thing people will always say about healthcare is it's the one industry where it seems like every market failure is happening at the same time, right? And so that's enough to make a lot of people throw up their hands and say, oh, we must need the government to run everything. We must need a single payer system where the government runs all the hospitals, like in Britain. And I'd argue that that's not the case, right? If we start thinking about what exactly some of these market failures mean, right? So what does it mean to have a public good? Does healthcare sound like that at all? Right, it's pretty easy to keep people from, getting surgery from you. And if you are conducting, say, heart surgery on one person, it's really hard to conduct heart surgery on another person at the same time. There was the one guy who would try to do 2 lobotomies at once, right? But it doesn't really work that way, right? So in the technical economic sense, healthcare is in no way a public good. So we can cross that one off. What about externalities? So we've got this one case in healthcare of contagious illness where there's a really clear externality, right? Because you being sick in a way that you could pass on to other people, like with a cold, right? That's not so good. You can get others sick, and if there's some treatment that can get rid of that, say like a vaccine preventing you from getting the flu, right? That's helping you, but it's helping everybody around you as well. You're not taking into account the full benefit to everybody else when you think about whether to get the flu vaccine, right? And so not enough people get it, right? There's a little problem there. Right? But does most healthcare work like that? Right? Turns out, in the rich world at least, most of the diseases we get aren't in any way contagious, right? Your heart disease isn't going to make other people get heart disease, right? Your cancer isn't going to make other people get cancer. Almost certainly. You can find some weird things like the Framingham Heart Study where obesity and heart disease do seem to be contagious, right? Because of your bad habits rubbing off on your friends, right? But for the most part, right, the actual externalities involved in healthcare are really small, right? Only apply to contagious disease. There's this asymmetric information problem where you know more about your own health than the insurance company does. Again, to the extent that this is a problem, it's almost certainly due to government regulations. And insurance companies are really good at finding out information about you or making you give them information when they're allowed to and when they want to. Right? So if you think about car insurance, life insurance, the markets for these work just fine because companies get lots of information about your risk. They're able to price policies well enough. Right? How about this thing at the bottom, moral hazard? So you're able to, you can offload your risk onto somebody else because you're not on the hook for costs. That's a pretty good description. And with these other market failures, I've been downplaying them, saying they're not really important. Moral hazard? No, this is a real market failure. This is real important. If anything, it's more important than it seems at first. Right? So let's think through this. When you're thinking about why healthcare is so expensive in the United States, I think a big part of how we end up using so much care and how prices end up getting so high is because there's rarely somebody in the system of providing care and getting care who's going to say no. Right? So you start thinking through the people in the healthcare system who could say no. Right? One would be consumers saying, I don't want to use so much care because it's too expensive. Right? This is how most goods work. Right? We don't think about people overspending and getting other sectors of the economy too big because spending's not bad. When people think something is too expensive, they just don't buy it. Right? But in healthcare, almost all care is paid for through health insurance. Right? As we saw at the beginning, out-of-pocket costs are only about 13% of the market. So everybody, almost nobody is paying for healthcare directly. Right? It's all being run through insurers. Right? And when insurers are paying, you're not so worried about the cost. It's sort of like going to a buffet, right? Where once you've already paid the price of admission, like once you've already paid the premiums to your insurer, you don't care about the cost of getting a little more food. Right? And as you've probably all seen this week in the cafeteria, right, that can lead people to eat more than they otherwise would. It certainly has worked that way for me. Right? So moral hazard in general means you don't have to worry about prices. In health, it gets even crazier than that. You almost never even know what the price is that you're not paying, right? That your insurer is on the hook for. Right? If you go look this up sometime after you do a doctor's office visit, if you can, see it say on an insurance company website, it's crazy. I went to get some allergy tests because the copay to do so was only $30. And I thought, hey, it'd be cool to know what I'm allergic to for $30. Right? And I looked later and saw my insurer had paid $1,200 for that visit to the allergist. Would I have paid $1,200 to go see the allergist and just, hey, find out, I wonder what I'm allergic to? I don't think so. Okay. So consumers aren't saying no. Right? Insurers would like to say no. Right? They'd like to say, you want to go see the allergist, but we don't think you really need to. Right? But they have a hard time doing this, right? Because consumers really, really hate it. Right? They really hate being told no by some bureaucrat who's not even a doctor most of the time, okay? Or by the fine print of some policy. And so we try really hard to avoid policies that are going to end up saying no. In the 90s, for a few years, there was a real slowdown in the growth of health spending in the United States as HMOs and managed care were getting popular. There was a big backlash against this, both politically and against employers who chose plans like this. Right? And the savings went away after 4 or 5 years. Right? And finally, there's government. Right? Government could be the one to say no, especially when they're the ones footing the bill, as they are with Medicare and Medicaid. But again, they've been very reluctant to do this for political reasons. Okay? When you even start talking about not having Medicare pay for treatments that don't actually help people's health, right? There's this huge outcry about death panels, right? And the whole proposal goes away. In other countries, somewhat miraculously, governments are actually pretty willing to say no to things. Right? And this is a big part of why spending increases in other countries have been lower. Right? And there are problems here, right? The governments in other countries are probably saying no to some treatments that should go forward, but the effect on savings is really clear. So one of my favorite things about health economics that the health economists have done was the Rand health insurance experiment. So this took place in the late 70s and early 80s, where the Rand Corporation, same people who did all this research about how to win the Cold War, they gave a couple thousand people free health insurance just to see what would happen. And they staggered the amount of co-insurance that people had to pay. So some people got a really bad plan where you still had to pay 95% of the cost, but they gave you some cash on the side, so you'd still take it. And other people got progressively better plans. Some people got this amazing plan, right, where we're giving you free health insurance with no copays, no co-insurance. Right, so you just get everything for free. That's the 0% co-insurance. And what they did is see what happens to people's use of care when you do this, right? How much more care are people using when they don't have to pay anything as opposed to when they have to pay half? And what they found is an elasticity of minus 0.2, right? So something like if you cut people's spending in half, if you give them, say, somewhat more generous insurance, their total use of healthcare will go up 20%. So they're not totally unresponsive to prices. It's not a huge response either, right? This is somewhat inelastic. But as healthcare gets cheaper, people use more of it, right? Demand curves slip downward. It's shocking, I know. The one really shocking part of this was, though, no improvement in health, right? So the people in this 0% group, they use a lot more healthcare for 5 years. And at the end, they're not measurably healthier in any way, except for eyesight, right? They get better glasses. Their teeth get a little better, right? But all the health stuff, right? Like looking at what happens to their blood pressure and things, right? No better at the end of 5 years. That was kind of interesting. Look up Robin Hanson. He's got a lot of great stuff to say about that, but I'm just sort of going to leave it there for now. Okay. So this Rand experiment is suggesting that insurance does make people spend a little more, okay? But not a ton, not enough to explain this huge rise in U.S. healthcare spending over the years. So how can we explain that? Well, at least in the case of Medicare, right, I think the insurance really can do it. Right? And so moral hazard really can explain a big chunk of our spending increase. And so why is Medicare different from this Rand health insurance experiment? Well, in the Rand experiment, we give a few thousand people free health care, right? And that changed their behavior. Right? It made it cheaper for them to go to the doctor more often and get more care when they were there. Right? But it doesn't change the whole nationwide healthcare system. Right? The way it does when you introduce a big new federal program like Medicare. Right? So now with Medicare, not only do individuals know that now I have this insurance that I didn't before, all the doctors know it too. Right? Every time a doctor sees somebody over 65, they figure, this is somebody who doesn't care about the price of the care I'm giving to them, right? I can just do whatever I think is medically necessary, right? At any cost, at any price, right? And they'll just agree to it. And Medicare will just agree to it, right? So I can prescribe all the care I want, do all the surgery I want, it'll be great, right? And not only do doctors know it, medical technology companies and hospitals know it. So now you know, if you come up with some great new medical device, there's going to be a big market for it, even if it's really expensive. Right? And if you're a hospital and people come up with these awesome new medical devices like MRI machines, right? And you know there's going to be this big market for it, even if it's really expensive. Right? So this huge nationwide health insurance plan of Medicare, leads to this big increase in spending, much bigger than you would expect just from the RAND numbers, about 6 times bigger. Right? So Amy Finkelstein, she's my favorite health economist. She's at MIT. She won the John Bates Clark Medal 2 years ago, I think, which is like our baby Nobel, best economist under 40. They only give it one a year, so it's actually harder to get than the economics Nobel Prize. And you should totally go read all her papers, right? But all this stuff is from evidence from the introduction of Medicare, right, where she looks at health spending, in the 1960s and early 70s, and sees that the places where the Medicare expansion was bigger, you get these much bigger increases in total healthcare spending. Right? You're running up against a limited supply of doctors, right? Doctors are changing how they practice. You're getting a lot of technology increases. And the craziest thing of all, right, the way Medicare worked for its first 2 decades was with cost-based reimbursement. So what this means is the more you spend treating your patients, the more money the federal government gives you. Right? Think about the incentives there for a second. Even if you could figure out a way to treat people more cheaply and efficiently, right, not only do you have no incentive to do so, right, you have the opposite incentive, right? The more you can spend taking care of a patient, the better. Right? And the increase in spending we saw reflected that. Right? In the 1980s, Medicare transitioned to a somewhat more sane system that's more like fee-for-service, right? Spending has slowed down a little bit. Okay, so why do we spend so much in the US? I would say Medicare is a big part of the story. It's not the only part of the story. One of the really interesting things about the US healthcare market that's keeping us way far from being a free market is all these restrictions on the supply side of healthcare. Right? So it's not just health insurance, which is affecting the demand side, affecting what people are willing to pay. We've got this stuff on the supply side saying that it's really hard to get a license to practice. Right? There have been historically these big restrictions on the number of people allowed into med school and the number of foreign doctors allowed to come into the country. Those have actually been getting a little better, eased up a little bit the last few years. But historically, the United States has had a really low number of doctors per capita compared to the other rich countries. Right? We've had about 2 per 1,000 historically compared to more like 4 per 1,000 in most other rich countries, per 1,000 citizens. So that meant the doctors we had could command really high prices. Right? We've made it traditionally really hard for non-doctor practitioners to practice on their own, right? Like nurse practitioners. Again, there's a lot of exciting stuff happening now. This is starting to change. Something like 20 states have made it easier for nurse practitioners to practice without doctor supervision. Nebraska just did this. So there was no psychologist basically in the entire western half of the state, psychiatrist in the entire western half of the state. And yet we still had these laws saying, hey, nurse practitioners of psychiatry, you still can't operate because you can't be supervised because there's no one to supervise you in the entire western half of the state. Right? Okay, so this has been a big restriction in the U.S., somewhat starting to change. And then these things called certificate of need laws. So these laws make you get permission from a state board before you open a new hospital or expand a hospital or expand another health facility like a dialysis center or some kinds of doctor's offices or nursing homes. Right? And yeah.
I was going to say the state of Missouri were actually one of the example states I believe where TADIS is used because severe certificate of need laws.
Yes. Yeah, and so you might be thinking, well, this doesn't sound so bad, right? Because it makes sense that you want to make sure that a facility is like capable of safely treating their patients, right? That it's high quality enough in terms of having the right staff, having the right equipment, and all that. That's not what these laws are doing at all, right? What the boards are certifying isn't that you're going to be a good provider. It's that it's economically necessary for you to be there, right? So instead of having the market predict or say like how much demand is there for your service, right? We're going to have a board of bureaucrats at the state level guess, right? And if they guess that the demand is not going to be there, we say you're not allowed. Right? You can't open. You can't expand. So the aim of these laws was supposedly, right, we're going to reduce spending, we're going to increase access, and we're going to increase quality with these laws. As you might guess, they seem to backfire on all counts. I've got one paper right now about quality, in which I find that all-cause mortality seems to go up a little bit in states that have these laws. And spending, it looks like not only do these laws not decrease spending, they actually increase spending. The Affordable Care Act, the new Democratic Congress starts working on this in 2009, passes in March 2010. Right? It's been very slow to be implemented, right? So very little of it actually took effect right in March 2010. Most of it took place in 2014, right? So we're just now starting to see the effects of it all. And as you probably know, pretty similar to the reform that happened in Massachusetts. So, a lot of the ACA is still new enough that it's hard to figure out how it's working. So a lot of people have been trying to look back at Massachusetts, see what's happening there, and use that to predict what's going to be happening in the next few years with the rollout of the ACA nationwide. Okay. So what did the ACA want to do? What were the goals of its proponents? Well, they wanted to reduce this idea that the US is the only place without universal coverage, right? That we've got this really high rate of uninsurance, we got to bring that down. They'd say the market for individual health insurance here is broken, right? We need new regulations to fix it. And to reduce this crazy increase in healthcare costs that you've been seeing, right? And in all of these counts, right, it was really a reform about health insurance, right? Almost all of the ACA is about reforms to the health insurance system, not really about health providers or hospitals or doctors directly in any way. So how is it going to try to achieve these goals, right? We're going to have a bunch of requirements about health insurance and who has to buy it or sell it, right? So we've got an individual mandate, right? This is what's directly binding all of you now, saying you've got to have health insurance. If you don't have health insurance, you can be fined or taxed up to an extra $700 for not having health insurance. Right? We've got this employer mandate, which is saying large employers need to provide health insurance to their employees. And again, if they don't, they can be fined up to $2,000. And we have guaranteed issue, right? So this one's targeting the insurers and saying you have to sell health insurance. Right? If somebody comes to you and asks to buy a plan from you, you can't just say denied, right? You have to say, okay, here's the plan. Here's how much it costs. So we've got those requirements telling people that they have to buy insurance and telling insurers that they have to sell insurance to anybody who asks. And then in order to make all this work, right, we have these things about access and affordability. Right? So right, if you tell people to buy insurance, they might not actually physically have enough cash to do that. Right? So we're going to do some things to try to bring the price down and to subsidize them and make it easier for them to go buy insurance. And again, with guaranteed issue, right, if you tell insurers you have to offer plans to anybody who asks, that's a pretty easy thing to do. Right? You can say, oh, of course, this guy with cancer, I'll offer him some health insurance. The premium is $1 million per month. Right? I've complied with the law. Right? So in order to close that loophole, we've got these community rating regulations, right? Where basically you can't do that. You have to offer everybody more or less the same price. Okay. So, right, kind of skip through this stuff. So the mandate, people have to buy insurance, right? And so we have to define what insurance is, and they define it pretty broadly, has to cover a lot of things. Okay. We've got the employer mandate. You've got to buy insurance for your employees. This is supposedly in effect now, although they have retroactively delayed it before. If we ever get rid of one major part of the ACA, it would probably be this, right? Since the administration themselves have been willing to delay this. And we had the fun spectacle of Republicans suing the administration to implement part of the ACA. Right? We hate the ACA, but we don't want you just not implementing it. Right? All right. Guaranteed issue, insurers have to sell. Community rating. This is kind of an interesting one, right? So community rating means when you're figuring out what premiums to charge, you have to sell everybody in the community health insurance at the same price as a first approximation. So, to everybody in San Francisco, right, you figure out what the San Francisco premium is, and that's what you offer everybody, right? And there are only a couple things we're going to allow you to change the premium for, right? So you can charge more for family plans and bigger families than for single plans. Right? You can charge old people more, right, but only up to 3 times more. Right? So 64-year-olds, you can only charge them up to 3 times more than you're charging the 18-year-olds. And tobacco users, you can charge them more, but only 50% more. Right? And that's it. These are the only reasons you can change the premiums, but we don't. All right, so we set up the exchanges. You've heard a lot about those in the news, and how well they are working or not. Right? Subsidies. So we pay people to get individual health insurance now because we told them they had to, and some of them didn't have enough money. Right? These subsidies do go up to a surprisingly high level, like 400% of the poverty line. But and then we've got this Medicaid expansion. Right? So we did this one expansion of subsidies, trying to get more people to buy individual health insurance, and then we've got this expansion of Medicaid, so the traditional government program to cover originally poor mothers and children. Now they're trying to expand it to cover all poor people, everybody below 133% of the poverty line. And we had this fun thing where this case went to the Supreme Court, and the Supreme Court said, the federal government, the ACA, is trying too hard to force this Medicaid expansion on states. Right? They are holding a gun to the head of states, right? And telling them, if you don't expand Medicaid in this way we want you to, we're going to pull all of your Medicaid funds. Right? And the Supreme Court said that's an undue influence. Right? You're holding a gun to their heads. You can't do that. Right? So now we get this fun map, right, where the green states accepted the federal Medicaid expansion. Right? The orangish states, Texas orange, they said no. And these blue states said, we'll take your money, but only with some conditions. Right? And a lot of this happened along party lines. Right? Republican governors especially really didn't want to take this money and be seen as supporting Obamacare. The most interesting thing to me, though, is what some of these blue states have been doing. Right? Think about this. Right? The federal government's offering you a bunch of money to expand Medicaid. What would you try to get in return? Yeah, if you could bargain for anything, yeah. You could ask for a lot of things. Right? You could ask for, I don't know, a new car for everybody in the state legislature, right? But the one really interesting thing that's going on right now with Medicaid is that Arkansas and Iowa, right? Somebody in Arkansas was actually really smart. They thought, we're getting all this money for Medicaid, but hey, we've got this new health exchange for individual insurance, right? Now, if the ACA worked, then it's going to be a lot easier to get an individual health insurance plan in Arkansas now. So why is it that we're providing Medicaid as this like government-run health insurance program? Why does the government have to run it? Why not just buy Medicaid recipients a real private plan? Right? The kind of plan that doctors will actually accept. Right? Well, it's this radical idea of giving poor people the same quality insurance that everybody else gets. Right? And it turns out you can actually do it for a pretty similar cost to this government-run Medicaid insurance that nobody will accept. Right? So that's what Arkansas is doing for everybody for the Medicaid expansion. Iowa gave people the option. New Hampshire is trying to give people the option. Okay? So this is going to be a cool thing to watch. Okay, so you look at Massachusetts, it does seem like this is bringing the rate of uninsurance down. Right? That shouldn't be a crazy idea. Right? You throw a bunch of money at something, you subsidize something, you get more of it. You subsidize insurance, you get more of it. You require people to buy insurance, at least some of them actually buy it. Really a surprisingly low amount, about 40% of them so far. Right? But uninsurance is going to go down. It is going down. Not to near zero, Massachusetts got it to near zero because they were this weird state to start with, a very rich state to start with. Right? In the US, we're probably going to get it down from 18% to maybe 10 or 12%. If I can again risk my free market economist card, I do a lot of research examining regulations about healthcare, and almost all the time I find that they have major costs and that their benefits are smaller than you'd expect. Right? So I've studied these health insurance benefit regulations and found that they have they lead to big increases in premiums, and they have all these bad effects on the labor market. They get people fired. So yeah, it would be nice if we could repeal those. It would be nice if we could repeal certificate of need regulations. There are lots of regulations that should probably go away. But if there's one regulation in the entire market that doesn't exist, that should exist, right? So libertarians, lots of existing regulations we want to go away. Sometimes once regulations are already there, we make peace with them, say they're not so bad, but we almost never want to add regulations, right? If I can add one regulation, it's that every hospital has to publicly post the price of every service they offer on a website.
Yes.
Yeah. Because this market, it really isn't characterized by perfect information, right? People have no idea what the prices are at all, right? And hospitals do a lot to try to keep it that way.